You're listening to Healthy Discussions, the podcast where we explore big issues and our guests' ideas about them. I'm your host, Zack, a junior doctor from Scotland. If you're interested in thinking critically about the world around us, then this is the podcast for you. On today's podcast, I'm speaking with Lord Nigel Crisp. Lord Crisp is a crossbench peer who sits in the House of Lords, meaning that he's politically independent. He was the chief executive of the English NHS and has also been permanent secretary of the UK Department for Health during the Blair years. He is the author of the book Health is Made at Home, Hospital is for Repairs, and sits on the BMJ Commission on the future of the NHS, making him the perfect person to talk to about some of the current problems facing it. Lord Crisp, welcome to the podcast.
Thank you.
I have to say, I've very much enjoyed reading your book, and it seems like it's quite a radical book in some senses, because it's about changing the whole way we think about health. And I wondered, what was it about your career that sort of gave you the ideas for this book?
Well, I ran the NHS and the Department of Health, and as you say, I was the only person who did them both, so I had two jobs at the same time, in 2000 to 2006. And then I went off to start working in Africa voluntarily. And in fact, my first book was called Turning the World Upside Down, which was about what we can learn about health from people in low and middle-income countries. Interesting point, because people without our resources, but just as bright as us, but didn't have our baggage of vested interests and our baggage of history, and in some ways could innovate differently. But one of the things I've learned in working in Africa now for something like 16, 17, 18 years or whatever it is we need to think about health. And we need to think about health and not just health care. Healthcare is fantastically important. And the wording that I've used in the book, the title of the book, I borrowed from a great friend of mine who was running the Ugandan health service at the same time as I was running the English health service. Health is made at home, hospitals are for repairs. And he used that in his work. He is actually trained as a cardiac surgeon, but he's ended up running the Ugandan health service, as I say, at the beginning of this century. And has really understood that, public health, the health of the public in whatever way, is really important. And that expression, health is made at home, is interesting because it emphasizes the home and the community and the society, but it also emphasizes creating. Health is made at home, health creation. And what I mean by health creation is addressing the causes of health. Now, you as a doctor, and colleagues listening to this, I've no doubt, have all been trained in the causes of disease.
Thinking about causes of disease, absolutely, and having a very medical model about how to fix those. But health creation is different, isn't it?
Yeah, there are three things and my views have moved on, developed even a bit further since I read that book in 2000. So there's healthcare, health services. That's where you health professionals are absolutely the leaders, and we want you to be really good at dealing with disease. There's prevention of disease, which is actually about what do you do about the causes of disease, and that may be air pollution, it may be obesity, and prevention tends to focus on individual things. And health creation, which is about the causes of health, is very much about creating the conditions for people to be healthy and helping them to be so.
So can you give me some sort of practical examples of this? Because people might have a really good understanding of, right, okay, I'm sick, I go to a hospital, the doctor checks me over and does something. But the idea of health creation involves very different kinds of people, doesn't it? You have all of these wonderful examples in the book, but none of whom are necessarily doctors. So how does that work?
Well, if you think about the three aspects of health, healthcare and health services is very much your domain, the professional's domain. Prevention is actually really government's domain. Only government can do something about traffic pollution, air pollution. Only government can do something about healthy foods, taking sugar out of our diet. You may recommend it as a professional, but it's only so government has to lead on prevention. And actually health creation, it's the people in society who will lead on that. There'll be, the great health creators are your parents for a start, Zach, and then maybe a good school, maybe good teachers, people who help you to develop as a rounded, confident, competent, healthy individual. Because health isn't an add-on. Health is part of all those things about that we want from life. It's about being able to fulfill yourself. It's about flourishing. And we do know what the causes of health are. We're starting to see them appearing in medical journals now. Some of them are terribly obvious around diet, for example, and exercise. Some are less obvious, but having a social network, not just not being lonely, but not being socially isolated. Being socially isolated, there's actually evidence now that it can, if you're really socially isolated, it can change the architecture of the brain. It can actually have physiological changes. So having a social network, having meaning and purpose in life. There was an interesting JAMA article, Journal of American Medical Association, a few years ago, which actually demonstrated this. And these are in these top medical journals that really get into research and the gold standard and so on. And having a meaning and purpose, and the meaning and purpose is, get something that gets you up in the morning. What's the point of living? These sort of things, and it may just be walking the dog, or it may be doing, whatever it is you do. So there's those. Another one is contact with nature, and again, you'll have seen lots of studies now of how there are actually physiological changes as a result of being in a green environment. But another one is actually about having some control in your life. Not being helpless, not being unable to do anything, having some measure of self-actualization or having some control, some level of autonomy. So it's a whole range of things which were never in your medical textbooks.
Yeah, and it's certainly something about that control idea that I think people feel is lacking in society at the moment. And what I really liked about some of the examples, like for example, like use the example of the TR14ers dance class in the book, and this was a group of people who were tackling social isolation, which we know is part of what causes ill health in terms of the social determinants of health. And they were all coming together in that sort of a way that's very difficult to measure what the real impact of it is. And you sort of make that clear in the book as well, that these are really difficult things to measure. But when you actually ask the people, well, what does this mean to you? And it's very clear that they're very, very positive about the difference that it makes in their life. I just wondered if you could reflect on that sort of a lot of these things about health creation being quite difficult to measure, quite difficult for the medical profession to get their head around sometimes, even though we know in our guts, well, being out in nature is important, eating healthily is important.
Yeah. Well, actually, one of the things is you can measure stuff like that now. So on the being in nature, you can measure the changes in the body, the slowing of the heartbeat, the calmness, the mood change. You can measure all that as well as you can measure changes in psychiatry now, as it were. But if I take the TR14ers and just tell the story a little bit more, it was actually founded by a policeman who was fed up of chasing young children in Camborne, right down in the south of the country in Cornwall, and decided to work with them. And so as you say, we ended up with this group of people over the last 15 years who run a dance club, and about 2,000 young people have been through it. There have been some evaluation from Exeter University now, and the evaluation has shown that there's some improvements in mental health and physical health. I mean, they're fairly general sort of things, though. But there's certainly some possibility of measuring that. But an interesting point about measurement, and why measurement can be an awful trap if you measure the wrong thing, is that the policeman got into trouble because his arrests went down because there was less crime, and he was being measured by the number of arrests he did, the number of cautions. So his superiors said, "Well, what are you doing?" And he said, well, I'm stopping them rather than actually doing it. But
And so his bosses weren't very happy with him about actually fixing the root
I mean,
cause of the
it's
problem.
not a picture of some bits of the NHS from time to time that you hit the target but miss the point, as it were. But you're absolutely right. And I do make the point in the book, as you say, that the study of how you evaluate some of this is still in the early stages. But you, as doctors, know it well. Your great Sir Harry Burns, who was the chief medical officer in Scotland, if you ever come across him, he's still active at Glasgow Caledonian, I believe. But he has this great saying, we bring people into hospital and sort them out, and then we put them back in the conditions which caused the problem in the first place.
Yeah.
Workless, bad housing, rotten environment, and so on. And then they come back. So you get that part of it, don't you?
And this is a point that you're quite good at making in the book about pointing out how these things don't really seem to stack up when you really think about it, and how your argument, I guess, is really like health creation stands in contrast to what's actually happening in the NHS and in the civil service a lot of the time. So, for example, you give the you use this quote from somebody who says, we're actually incentivizing illness because we pay the people who are treating the complications of disease a very large amount, the specialists in the hospital. We're actually paying the people who are preventing this or promoting factors that improve people's health. There's very little funding, it seems, available, and the funding can be quite precarious from government. So to come to a question about that, I suppose, what have you learned in your time about what the NHS and government are doing that is making this health creation process more difficult?
Well, let me just source that quotation that you gave. It was actually from the South African Minister of Health, Dr. Aaron. What's a lady who's essentially a GP, but he was a successful Minister of Health. Who actually, if you know the history in South Africa, was the one who actually ended up leading the HIV/AIDS response. But and it's a good quotation. Yeah. Well, what happens is that our planning system. I mean, I'm going to take you right outside health now, because the NHS should be focused on disease. I mean, I'm going to have a knee replacement fairly soon.
Congratulations.
Absolutely, a compartmental one, so half knee. But and in some ways, that's a result of too much exercise and too much sport. So even if you're living a relatively healthy lifestyle, we need the service bit. So this isn't an and or. So this isn't an either or. It's an and as well, and. So we do need all these approaches. But what government does in areas like housing, in areas like planning, just the planning system takes no account of its impact on health.
Mhm.
It's literally not in it. It takes account of environmental issues, but it doesn't take account of health. So all those other sectors which can influence our health negatively and positively, because there's both here, there's no government policy around that at all.
And is that something we can easily fix?
Well, it's something that we can fix. I had in Parliament, in both Commons and the Lords, you have what are called private members' bills, which means that you're able to put forward a bill. And I put forward a bill called the Healthy Homes Bill, which actually said that all homes built, this would have to be only in England, because Scotland would have their own,
Yeah.
and Wales indeed. But all homes in England had to meet certain standards of space. They certainly had to have access to green space as well, actually. But insulation, a whole range of issues. There were about 11 of them, of certain standards that need to be met in order for these homes not to be a drag on your health. And you, as a doctor, will have seen older people who've fallen down. You'll have seen people suffering perhaps from over either heat stress or cold as a result of the homes, or damp.
Definitely in Scotland, it tends to be cold rather than the heat.
The heat stress may come your way, Zack, in due course. But you know, you see the negative bits, but actually, a home is also the foundation of your life. Really, if you've got a secure home, and people who are homeless, or a lot of young people who, have to leave their rented accommodation every year because for whatever reason, the landlords are doing things and so on. All of that really disrupts life.
Yeah.
So we need policies in health, in housing that are around health. We need policies in planning. We need policies in education and so on. So these would be the big push I'd be going for. Health professionals can help, and I'll tell you about that.
Yeah, so what can NHS professionals do to help? Because some people might, I'm thinking of people in my position where, I'm a medical registrar in the hospital. I know about social determinants of health. I know that my patient in front of me, if they come in with alcohol problems or, they live a chaotic lifestyle, I know that there's very little I can do to help them with that. If a patient comes in with obesity, I know that I can't, close down the fish and chip shop where they're getting most of their calories. Or, if I'm seeing someone with type 2 diabetes, I can give them a leaflet about healthy eating, but it's really up to that person, and I can't be with them the whole time. So what can we do to start promoting this idea?
Yeah, well, it does depend precisely what job you've got, because in some cases it'll be easier
Mhm.
than in others, and obviously a GP is going to be much more at the front end of this. But actually, if we go back to the point about what works and what doesn't work, you have a good idea about that. You know the questions that you would ask, and people in the community can think, well, what we've got to do is we've got to do X or we've got to do Y, and actually there's no evidence about it. And actually you may even have some counter evidence about it. So if I were setting up some kind of community activity that was related to health in some sort of way, or that I thought was going to be related to health,
Mhm.
um, I would look for health professionals to advise me, to influence, to help shape. And I think you've got a great role as health professionals, as agents of change and
Mhm.
curators of knowledge. Um, and that's the sort of agents of change where you make things, you help people to do things. There's an example in the book of Heather Henry, isn't there? I think if you've
Mhm.
got to her, who's a nurse working in an area, and she worked in an area and realised that some of the biggest asset in the area was some of the problem, one that was generally seen as a big problem, which was unemployed men.
Mhm.
Well, actually, unemployed men of working age, there was lots of stuff they could do, and she got working with them and helped them to sort of do that. And as she said, she started off at the front of the room working with them, but she ended up at the back. They took
Mhm.
control for themselves. So there's a big, and that's an interesting role, I think, agents of change and curators of knowledge.
Mhm. And this is something interesting the idea about health creation is about bringing people together who have similar problems and then letting them come up with a solution by themselves. I just kind of wanted to ask a little bit about that because some people might listen to this, oh, agents of change, and think, oh, that's a bit of a radical idea. That sounds a bit politically sort of active. But then on the other hand, individual people taking more responsibility for their own health. That sounds a bit more of like a conservative idea, or an idea about the big society, which was David Cameron's sort of big idea. So, do you see this as something that's political, or do you see it as something that's above that? I'd be really interested to get your thoughts on that.
Yeah, well, I don't see it as political. I mean, you can take it as political, but a lot of doctors have been active in
Hmm.
influencing society. And I said at the beginning, it depends on your role. Now, if you're a general medical registrar, I can imagine what your daytime job is,
Yeah.
and that you're pretty busy dealing with, responding, you know,
Hmm.
responding, not necessarily initiating. But if you happen to be a nephrologist, and working with some of the same kidney patients for years, which some of them do, of course, um, then you will. Uh,
Then you might start to think, oh, right, I'm encountering the same problem over and over again. Why is that happening? Maybe I can do something
People
about
have done
that.
this for years, you know. I mean,
Yeah.
it's in certain specialities like that, or a hepatologist working with alcoholic problems and so on, or indeed, of course, GPs. And there are some GPs, I haven't come across any in Scotland, but that's probably because I live in the south of England now. Um, but GPs in the south of England who are actively going out of their way to help develop activity in the community.
Mhm.
Growing health together, they call it. So there are those sort of roles, and they can be coming from a left wing perspective or a right wing perspective. Doesn't really matter. But I do think it's a tradition that for a lot of doctors that you do try and influence the public.
Mhm.
Um, and some people, of course, are very far out in trying to make change happen. Um, but and it seems to me entirely reasonable. Shall I, if I talk a little bit about where that came from, actually, because it wasn't just something that sprung out of my.
Yeah, I'd love to hear the story behind it.
Yeah. Well, I chair, or used to chair, because it's closed down now, an all-party parliamentary group on global health. So an all-party parliamentary group is a group of parliamentarians interested in global health. And we did a series of reports over the years. And one we decided to look at is what will 25-year-old doctors and nurses be doing when they're 45?
Mhm.
Because your job is going to change. I think,
I think I'm squarely in that demographic.
will be. Well, when you're running the system, age 45, though of course registrars probably run the system anyway, or a lot of it. But when you're 45 and in that sort of absolute prime of your career, what are you going to be doing? Because life is going to be so different. I mean,
Mhm.
it was 20 years ago for your predecessors, and 20 years before that. So we did this study across the world, talking to some senior people and some newly qualified, not just doctors, but doctors and nurses, but predominantly doctors, as it happens.
Mhm.
Um, and of course, and we produced this report, which was probable futures and radical possibilities. Um, and the two biggest themes that came out of it, of course, was technology.
Mhm.
You have to be so much more competent in technology than your predecessors, and in 20 years' time, well, with AI and everything else, it's going to be a different world, isn't it? And
Mhm.
it's going to be a basic part of your qualification to be a medic, to be
Mhm.
completely competent in that, and it'll shape the way you think, and it'll do all kinds of things.
Yeah.
But we also got from quite a lot of young doctors saying, hang on a moment, AI, protocols, stronger management systems, all that focus. Where's the space for me as a professional to make judgments? You
Mhm.
know, am I expected that I just have to do the AI, plug in the AI, as it were, follow the protocol and so on? And what am I going to be doing as a professional?
Mhm.
And it was partly out of that people talked about maybe that gave them more time to be with their patients
Yeah.
if
Yeah.
some of those things and the decision support were taken away from you, but also that actually there was a role in which you could influence people's behaviour
Mhm.
and system behaviour, and that's where it came from. So it was a global idea. It wasn't.
Mhm.
I mean, I've polished it, if you
Yeah.
like, in the words. And the idea of curators of knowledge. It's not that you're a source of knowledge, because of course you are, but knowledge is so contested these days. But you can help people to find the right knowledge.
Mhm.
You can help people to think about knowledge. You can help people to think that actually you need evidence before you just dive in with some intervention.
Mhm.
Yeah,
And your ideas are making me sort of think that. So me as a young professional at the moment, I feel like the NHS is facing like a real sort of decision point. There's a real moment of crisis in terms of
I
it's
agree.
starting to become apparent that our model doesn't seem to be sustainable about how we're dealing with the problem of health. There are many more older people who are sick in lots of different ways now, not just one way, and we've got fewer people to look
Yeah,
after them. And on the one hand, we've got this idea of health creation. Wouldn't it be great if we could prevent a lot of these people coming in? And yet, actually, a lot of patients are now coming to the A&E because of mental health problems, because there's no community support for them, and they don't know where else to go. So I suppose my question is, what would your advice be for someone trying to like square that? I want to do all of this stuff to make people's health better, but at the same time, there's just this never-ending queue of people coming into the A&E, not because there's anything that we can do about it, but because they don't know where else to turn.
Yeah. No, you're speaking absolutely like all the medical registrars I think I've ever met, Zach, actually. But I think the
I'm
problem
glad that I'm on brand.
Absolutely. Now, I used to run the Oxford teaching hospitals, and I knew the people there. And what was happening on the medical wards was absolutely symptomatic of what was happening
Mhm.
in the whole of the hospital. And the medical reg, or indeed the senior registrar in those days, were absolutely critical figures. But you're just responding. I mean, you're
Yeah.
not just responding, but you are responding. Um, the issue for government is that it needs an NHS strategy, but it also needs a health strategy. So
Mhm.
not just a health services strategy. And government hasn't got past the idea that health is your responsibility, Zach. You
Mhm.
know, they think it's down to you and the professionals to sort out. They don't accept they may do accept it intellectually, that actually if we create the conditions in society for people to be healthy, then hospitals can do what only you can do. You can do the vital stuff that we really need you to do, but some of the rest of it, and particularly for older people, and I'm now in my 70s, um, you know,
That makes you still young for my demographic, believe me.
I know it does. I know it does. It makes me just about up to the average of the House of Lords as well. Um, so I have the same demographic, except my demographic's healthier on the whole. Um, but one is conscious that that older people with comorbidities are going to be are just continuing to be the big issue of the future.
Mhm.
But what can be done to support people like me and others um, to be healthy?
Yeah.
And that
I suppose that's my question. What should be in that dream health strategy? If you could take whatever stroke of the pen you wanted, and what would be in that strategy?
Oh, I mean, some very specific things. I mean, firstly, my healthy homes bill. you
Hmm.
know. So actually, homes didn't damage you;
Yeah.
they looked after you. Um, Similar things around education, similar things around planning, but also a change in the narrative. And government can help with that change in the narrative. So can the health leaders, not necessarily the NHS chief executives of NHS Scotland and so on,
Mhm.
um, though they can help. But actually, your royal colleges can. You know,
Mhm.
yeah, you can. I'm an honorary fellow of your Royal College, assuming you're Royal College of Physicians, or you're the Royal College of Physicians of Edinburgh. There, aren't you?
I'm the Royal College of Physicians of Edinburgh. I was actually chatting to the president yesterday. We were recording a podcast about AI.
All right.
So yeah.
Yeah. Well, I think people in those sort of roles can help to change the narrative that we're talking about here,
Mhm.
because you as individual doctors, even if in your however many hours a week you work, you're responding and pressured, how you think about it is the most important thing. And if I just tell you about one other initiative, which isn't in that book,
Mhm.
um, it's a number of young doctors, particularly, and students who want to change the whole medical model, the whole biomedical model,
Mhm.
to a model that is a biopsychosocial
Yeah.
environmental model. And they're coming together to try and pressurize the medical schools, because the biggest change we need, government can do a lot, but the biggest change we need is in your head. Is if we believe what doctors tell us. We may be getting cynical in all kinds of ways, but actually nurses beat you on trust, don't they? In
Mhm.
the scores on trust. But we by and large trust our professionals, and part of that is because there isn't a money transaction between us.
Yeah.
We know you're not selling us stuff, um, and uh, in that sort of context, we how you think about the world is how we will think about the world. And
Mhm.
if you, as doctors and nurses coming through, are seeing the health service bit as a vital component of a bigger thing, and you're constantly thinking, what should we do? What should we do here? The young man who runs this thing, which is called Hope for the Future, and will be launched sometime later on, and has got some Scottish people and Welsh
Mhm.
people and English people involved in it. Um, he was telling me anecdotally about working in A&E in Croydon, and he was seeing some of the same patients, and he actually was spending some time with some of them to actually try and get them to do things differently rather than just patch them up. And he got told off by his consultant for doing it.
Mhm.
Why are you wasting your time? That's not your job. You're not a social worker. Not that there were any social workers there.
So it's that sort of mind shift that
Yeah.
I feel like the incentives aren't always there to
I,
think differently. And what's interesting about the work that you do is that you can see the whole bigger picture. It's not just about the NHS. This is going to involve government. It's going to involve the civil service. But each of these organizations has incentives that stop them from working with the other organizations, that keep people thinking about, oh, what are the short term quick wins that I can get? And not so much the long term planning that everybody seems to agree, we need. If the NHS was able to take a long term view of what would improve people's health, maybe it would do things differently. How do we align those incentives? Because I think that's a really interesting question.
oh, I think it's a hugely important question, Zach. I've had two recent articles in the BMJ, one just from me in July last year, and one in I guess it was January, with a small group who were part of the NHS Commission, the
Mhm.
BMJ's NHS Commission. Um, and in both of them, we sort of set out some of the things that need to be done. And one of them is something about vision.
Mhm.
You know? Actually, I became chief executive of the NHS in England in 2000 at a time when the NHS was in a bad state, not
Yeah.
as bad as it is now. Waiting lists were long, of the lot of MRSA infections actually.
Well,
Uh,
we actually use the example of near the end of your tenure as the good old days that we want to try to get back to. So that's quite a nice position to be in some ways.
yeah, but do you know what government did in 2000?
Mhm.
They actually set out a vision. It wasn't the same vision as you'd have now. It was about modernisation. Um,
Mhm.
but they also set out a plan, and they got people to help them create that plan. So they owned that plan. So the forward to the NHS plan was signed off by people like the BMA president, the RCN president, and so on, and some of the royal colleges and others. So there was momentum, because you can actually carry on doing the really hard stuff you're doing if you know there's a light at the end of the tunnel, if you know
Yeah.
where you're going. And I would guess if I were a young doctor today, I wouldn't know what the future held, but I'd be pretty pessimistic about it
Yes.
on current standards. Is
I mean,
anybody
I'm a insufferable optimist, but yeah, certainly I think my colleagues actually find it quite difficult to know what am I doing this for, and that's why we see people thinking, oh, I'll go away to, if there's no purpose for me here, I'll go away to Australia or I'll go away to New Zealand. I might as well have fun, rather than try to help to solve the problem, because people just don't feel like that's an option. They don't know how to contribute.
and that's where we need a picture of where you're going, of where we're going, and I just don't think we have it. And I have a niece actually who's the same age as you, and on the same sort of path. In fact, actually has
Mhm.
just been working in Edinburgh, but has come back down to London.
Oh.
um, and the sense I get from her and her friends and others is, where's the hope?
Mhm.
And I think that is a really sad thing if we haven't got that. And I think a new government coming in, maybe two new governments coming in, I appreciate you're in Scotland or indeed
Yeah.
in Wales or wherever, that actually sets out that we believe in these things about the NHS. This
Mhm.
is where we're trying to take you. Yes, it's going to take us 5, 10 years to get there. These are the first steps. Will you be part? Will you work with us to achieve it?
Yeah.
Now, that I think would, sorry, I don't just think, I know that motivated people when we were in a hole in 2000. Um, you
Yeah,
know,
I wonder if you could talk a little bit about what that time was like working with Tony Blair's government. What lessons did you learn about how to turn the NHS round that might be relevant to today?
yeah, well, the BMJ article actually picks up the good and the bad, and I'll pick up the good and the bad.
Yeah.
I mean, the good is, for goodness sake, politicians can't sort this, but they can play a role in sorting it by
Mhm.
working with you and your colleagues and actually the general public. So I would be so the first big thing was creating the NHS plan. They did it in 12 weeks over one summer, um, and people came together and worked on it, and it came out. It came out with 200 targets.
Wow.
I was appointed chief executive to deliver them. Um, uh, my father said, it's the longest suicide note I've seen for any chief executive, because you can't deliver 200 targets. Um, and that was one of the downsides, is that actually targets can be helpful if they're well chosen.
Mhm.
Um, and they are, I mean, I remember there was one which was an entirely sensible one. For the day, you'd do it differently now, but revascularization after an MI. The way that you handle that. I mean, and now you do it in a different way from
Yeah.
but with access to clot busting drugs and so on, and a requirement that whatever the percentage of patients who had a suspected MI got a
Mhm.
clot busting drug within a period. Now, some of that sounds like a protocol, and it is a very appropriate sort of thing. Some of the others weren't, and there were political pressures to recruit more staff. Now, we did need more staff, but we needed the right staff.
Yeah.
And sometimes the staff weren't, necessarily absolutely the right people you wanted, but also they weren't recruited on some of the newer job descriptions.
Mhm.
So people might still be recruiting systems and creating models for the 1990s, even though this was the 2000s.
Mhm.
You know,
So it
so
sounds like what it's going to take is really detailed thinking about exactly what measures or what are the goals that we have for the NHS, and trying to make sure that those aren't going to create perverse incentives to,
yeah,
or try to sort of just make something look good when it's not actually what we want.
that's exactly right. But part of that is a willingness to change the plan if it's not working.
Mhm.
One of the interesting things about all these health creators is they change the plan if it's not working. They know where they're going. They've got a purpose and a vision. They know where they're going. If the plan's not working, they change it. The NHS and bureaucracies find it very difficult to change the plan,
Yeah.
or to change the targets, and the newspapers and so on, the media
And
don't
is
have.
that a question of personnel? Is that a question of just the particular people that are in decision making roles in parts of the public sector? What's the answer to that? Because I feel like that's a really fundamental question. How can you get people in a large organization to be more agile, like these health creators that are, able to they are able to change things, but are working on a very small scale.
Well, I think the answer is it's inherent in any bureaucracy that you end up, because if you were in an organization with 200 people, well, you as a chief exec, you can know them all, at least
Yeah.
by face and name, and so on. But if you're in a big organization, you end up having rules. And it's the ability to change those rules. And we've tended to, and particularly when you've got it in a political system, if the government says we're going to do this, it's then very difficult for them to say, hang on, that's not working. You
Yeah.
can imagine what the opposition do to that. But actually, it's helpful if um, they've got a healthy relationship with the medical leaders, including the junior doctors, because I know you're called junior doctors, but you're actually, in leadership roles, let's be clear.
That's very kind of you.
Well, they absolutely are doctors in training. And that if you can explain to the public, well, it was actually very reasonable that they stopped, that we moved away from doing X, to doing Y, and that was the appropriate thing to do. And if because third party validation is always important.
Mhm.
If I say I'm doing good things, well, you're a bit skeptical, aren't you? But
Mhm.
if somebody over there who's not connected with me says I'm doing it right, then that's okay.
I think even you saying that made me realize how unusual it is to have somebody, in Parliament saying something that values the contribution of junior doctors in a meaningful way. So like that was really nice to hear. I
Isn't that
think.
isn't that terrible, actually, Zach? And I have to say, one of the things we did was we used the Prime Minister.
Mhm.
So we got the Prime Minister to have a whole series um, of meetings and come out. He used to come to my management meetings. I had Blair at my management meetings about 3 or 4 times.
Mhm.
About every 6 months or something, he'd come to management meetings. They were there, and they'd say, well, they'd hold you to account, but they'd also say, well done.
It's definitely important for morale, I think.
Yeah,
The other thing that I think is important in having any sort of conversation about the NHS, I think people always worry about the extent to which the market should get involved. And I know that during the Tony Blair government, a sort of quasi market was
yeah,
introduced,
yeah.
and kind of since then we've had sort of changes to that. So I just kind of wondered. You talked about there being a bit of a tension between people that saw healthcare in a sort of consumerist way, of this is a commodity, I should have choice, and
Yeah.
other people in the government who took much more of a traditional public health approach of where we're going to use the state in these ways to try and make people's health better. What is there a balance to be struck between those two things, and where do you think?
It's difficult to be absolutely dogmatic about this. The history of it is that I remember when I was running London, which I was running before I was the NHS in London, before I was running the England. We wanted to try and use the private sector to get waiting lists down, and the
Mhm.
Conservative government of that day wouldn't let us.
I
Um,
see.
and
That's
they
interesting.
and that was partly because they knew they would be attacked for privatising the NHS. They also knew that in their period in office, the NHS had got worse. Um, but when Labour came in, they were able to do that because, of course, the public more or less trusted Labour. But you've
And
got to
that's
go through.
very similar to what Wes Streeting is saying at the moment about trying to use private sector to get the waiting lists down, isn't it?
Yeah, well, you've got to do it in the right way. I mean, one very interesting observation I had was that um, when we first wanted to use the private sector, we said to the British private sector, "You need to do it at our prices, and you need to do it to our standards, which in some ways are higher, as you well understand,
Mhm.
including the fact that in some private hospitals you don't have medics there overnight necessarily, and so on.
Mhm.
Whereas the hospital you work in, I'm sure you've got a whole range of specialities every night." Um, uh, and so on. And they refused. So we brought in some South Africans ophthalmologists first. And I reckon by the time those ophthalmologists had done, I don't know, 3 sessions, 30 patients or something, British ophthalmologists were changing. And
Yeah.
we saw the waiting list start to come down because actually you saw an impact of competition. You saw the fact that in Surrey, there's a train line between Surrey and London.
Mhm.
In Surrey, the waiting list for cataracts was 18 months. In London, in some parts of London, around Moorfields and so on, it was 6 months.
Mhm.
So why weren't you sending people between them? So there was some very obvious, pragmatic, practical things to do. The danger comes when you become ideological and you think that either sector necessarily is better than the other, or that the private sector is better than the other, and they stuck to the private sector too far, in my view.
Mhm.
But you, as the NHS, need to control the input. You need to decide what patients they see. Now, it may well be that it is the easier ones. So it may be the hips and knees, but not the redos.
Yeah.
You know, it may be the straightforward procedures, but you need to decide that, not necessarily let the private sector decide that.
Yeah.
Um, but after the waiting list started to come down, the private sector in England then wanted to work with the NHS and
Mhm.
does now.
I wonder if I can see what you think of some of my objections to how private healthcare has expanded within the NHS
Yeah,
since your time and under the Conservatives, because I see like a few different things going on. I see how private companies have sort of fragmented the NHS. So instead of having a NHS board or trust that was responsible for an area, now you have lots of providers or integrated joint boards, or that used to be the clinical commissioning groups that aren't necessarily connected to an area and are starting to compete with each other and duplicate work that I kind of think, oh, it'd be much more efficient if you were all just working together on this. So that's sort of one thing I want to get your ideas about. And then also the sort of the difference between some of the private providers or the private companies that you talk about as health creators that are, small agile business model, and then maybe more predatory businesses that are their business models about taking government contracts and government money and trying to provide as little as possible because that's where the profit comes from.
Yeah, no, absolutely, both of those things. I totally agree with you about the joined upness and the dangers of that. The private sector needs to be your subcontractors, you
Hmm.
know, and you do need an area-based approach, obviously in primary care, but also even in big teaching hospitals. You need. When I was in Oxford, I mean, we were conscious that there were 600,000 immediately around us, but we actually provided some support to a population of 2 million, and you had to think about the 2 million and not just the 600,000 within it. Now, I'm not familiar with the Scottish system at the moment. I'm not all that familiar in some ways with the English system.
That is okay. I was not expecting a deep knowledge of the Scottish system.
Yeah, but there is some attempt under the last chief executive to bring together these integrated care boards. Now, the danger is, will they just end up being talking shops as opposed to being, people who have some ownership? So I do think there's some real issues there, and you're absolutely right. Fragmentation is the great danger. If you have to one of the problems in the NHS anyway is that for older people with comorbidities, I've got to go to that hospital for this. I've got to go to that hospital for that.
Mhm.
My eyes or my legs or my head, in different sort of directions.
It's just not very efficient, is it?
No, so you need whatever it is that will make that come together. You of course, you may well need somebody who's actually looking after your total care, which is of course where GPs have been in the past, but not
Mhm.
necessarily now. So I do agree that is a major problem. I also think there is something that you're quite right about pointing to, which is that there are private sector small things, and there are, frankly, not pulling punches. Some of the big American private sector companies, who, as you say, are just in the business of profit. Their
Mhm.
job is profit, and healthcare happens to be one of their areas, as it
Mhm.
were. And this is true elsewhere. Now, that doesn't preclude some of them, of course, providing good services.
Mhm.
Um, but it goes back to the point about actually, and we haven't touched on this really. You do need quite a lot of decentralisation. You do need, you know, if there was, and I don't know if there is, somebody in Edinburgh who was responsible for making sure the Edinburgh NHS worked. I don't know if there is,
Mhm.
um, and who was publicly known. I'm not.
I think they have like there'll be the chief executive of NHS Lothian. So they're I think Scotland's managed to retain the geographic nature of the boards.
Yeah, I mean England has to some extent, but it's not quite. But we had too many reorganisations, which was
Hmm.
another problem. Um, you do need an element of competition in this, though, because otherwise, if it becomes too cosy, then you get the sort of. I mean, if you will have seen the infected blood scandal.
Yes, yeah, no, I definitely wanted to ask you about that as well.
Yeah, well, go back, into the 70s and 80s, um, and it was a different culture, of course.
Hmm.
Um, but people were taking decisions completely off their own bats without challenge.
Hmm.
Doctors were next to God in a way that you're not now, although
Yeah.
you are, very important. But there's clearly people were felt it was reasonable. I mean, extraordinary things happened then,
So
and
because there was no transparency or no oversight or no competition between the leadership of different boards, doctors were able to basically infect people with blood, giving them blood transfusions they didn't need without any consequences at all.
yeah, I mean, an individual professor who had obviously led all that sort of trials and so on may have thought, I don't know, have no insight, may have thought that he was doing a good thing,
Mhm.
because he was pressing on with medical science, but at the cost of
Yeah.
doing things that are completely deplorable. So if you don't have light in, if it gets too cosy and there isn't,
Hmm.
uh, uh, you know, that old boy is, the Bristol Heart inquiry in just before I was chief exec, where the person who did it referred to the club culture
Yeah.
amongst the surgeons, and he's a good old boy, so we'll rely on him, and that kind of stuff.
And that's quite a tricky policy problem to, how do you change a culture of an organization? I suppose the answer's, well, it kind of depends on the people in the organization, and it sort of maybe depends on how the rules are set up.
It is a mixture of both, but the most important is the people. And one of the things I've learned, despite running an organization with 1.4 million people in it, is that relationships are what count. And if I had good relationships with the top 100 managers and the Royal Colleges and so on, then, and if they had then good relationships with the next 100, you've got 10,000 people, who are pointing in the right way. Now, the rules should reinforce that. But if it's a case of would I go for good relationships, by which I don't mean he's a good old boy sort of relationships. I mean straightforward, being able to discuss with you, Zack, my patients in an honest way if I had any patients.
And having that trust.
Yeah, and so on. But if I had to choose between relationships and systems, relationships come first and then systems. And that's a message as well that come from the health creators, actually.
I think that's a very important lesson. Just while we're on the topic of sort of the debate around the NHS that's happening, sometimes you hear things about changing the funding model, and people say things like, "Oh, wouldn't it be better if we had a European style insurance system?" And I've even heard some of my colleagues saying, because of the problems they're experiencing, "Oh, surely they've got to privatize it now." And those things always make me really worried. And so I was interested to ask you this question, because I think you've said in an article, like, changing the funding model won't actually solve those fundamental challenges that the NHS has. I wonder if you could tell us a little bit more about the reasons behind that.
There's my background's philosophy, actually. So I have a degree in philosophy in Cambridge. So there's something called a category mistake. The issue we're dealing with here is a health issue. There is a money issue, but actually, until you've decided how you're going to deal with the health issue, then think about the money and get it that way around. If you think about the money, you will you'll be in danger of just missing some of the things to do with health. So actually, you need to think about your health model, and our health model needs to reinforce the community, reinforce primary care, pick up on health creation and prevention and all the rest of it. I mean, I think a lot of people think that, and that's the way for us to go. So it is different, but there's also a big issue. If you want to change the financial model, we have, you won't hear the press saying that, but we have very low overheads. Because if you think about it, the money is being raised anyway through the tax system, because basically it's tax, not entirely, but the big bulk of it is tax.
So hospitals don't have to spend money fundraising and advertising because they get their money from government that's already provided for.
That's right. So in America, there's something like a 15% overhead, which is the insurance companies. So and doing all those sort of stuff. And there'd be and of course there'd be a cost of you'd have to get out your card machine every time a patient came to see you, or somebody would be employed to
somebody's card would have to come out.
You have somebody in your system who was managing that, but even that's not the same thing, because you could argue that you would have a social insurance system like like the Dutch shifted to, actually. Well, it's slightly different, but the German system is often thought of as being the one. Now, there's some interesting features of those systems. In general, the German one, for example, charges most of the cost falls on people in work, not on the elderly. Whereas actually, you might think more ought to fall on the elderly. I know we've been in work, but but there are less of you compared to the number of us these days. But there's also the cost of change. We did actually look at whether we should introduce some kind of social insurance model in the Blair years, fairly early on in maybe
Oh, that's interesting.
2000, 2001. We had a little strategy unit and they looked at it. And there's a huge cost of change,
Mhm.
So you've got to be convinced that the 2 or 3 billion that it would cost you just to set the system up is going to result in at least £2 or 3 billion worth of better.
And that
Service.
sounds like too big a gamble to take.
It's a pretty big gamble. You've got to be pretty clear on it. I mean, the Norwegian, not Norwegians, the Dutch did it. They set up 3 state insurance systems in competition. It put up the costs for the whole system so that they're one of the most expensive in Europe. And there's a lot of contested views about how successful it is.
Oh,
Um,
that's interesting.
but so there are models to look at.
Mhm.
But I think these things are quite cultural, and keeping it in the way that it is has a lot of advantages. Why don't we try and sort out the health problem? And if at the end we decide that the financial model needs to shift, it should shift in response to the health model,
Yeah.
not in advance of the health model.
And do you think politicians are being honest enough in the debate that's going to be coming up about the future of the NHS in relation to the election? Because I kind of think that the politicians are kind of pretending that we can have it all, and that conversation is going to be a nice conversation, whereas I think it might be actually quite a difficult one. If you want to carry on the NHS doing what it's doing, but you accept that the model might not be sustainable, well, how are we going to deal with that? Are we saying that the NHS shouldn't pay for all care, that there might be some kinds of care that are too expensive to be funded on the NHS? Or are we saying that, well, it's going to depend on, we're going to cover certain people, but maybe not the poorest in society. We're going to stop providing, things for people in some areas because their hospitals can't provide it for them. The postcode lottery, for example.
Yeah, well, that's what's happening at the moment to some extent, isn't it?
Mhm.
And it will tend to affect the poorer people in society more for all the reasons that we know. Um, Not being honest, well, politicians are they've got a whole range of different views, of course. And I suspect there are some people who aren't coming out with the fact that they think it should just be privatised, because I've no doubt there are some politicians who are completely in that area. I think there are others who are saying, well, to what extent have we really tried to limit, to handle prevention and health creation and actually move some of the work back out of hospitals? And some of them may not be being honest, or maybe all of us are not being entirely honest, that actually if we move to the sort of system I'm talking about, it will affect the services in some hospitals.
Mhm.
Um, you know, we will see more centralisation of some services, um, because inevitably, I mean, it's happened in my time. I remember how we centralised vascular surgery, for example, whereas actually quite a lot of people did vascular surgery and actually set up the cancer networks in England
Mhm.
and so on. And actually, urology came out of general surgery and so on. So you have to sort of um, recognise that there'll be some really quite big impacts. And if you happen to be somebody who has trained all their life to do a particular speciality and then you don't, and then it's taken away because it's gone to the teaching hospital, 40 miles away, um, you as a professional will find that pretty hard.
Well, it's been a fascinating conversation. Just before we end, obviously, your book "Health is Made at Home" available in all good bookshops. But is there any way we can find out about some of your other work that might be upcoming? Is there? I know you're working with the BMJ at the moment on this commission. I just wonder what might be coming up in the pipeline for you.
Well, the commission, there's going to be a meeting sometime in the next few weeks to try and think about what next. They've published a series of papers, as you would have seen, of which the one that I was talking about, I wrote well, it was the first one. Um, so I'm not sure where that's going. I do think look out for this thing called Hope for the Future, which will have a soft launch in January and then some kind of massive a soft launch in July, early July, and then have a major conference of some sort, Zoom conference, not just in person, in September, to sort of seek to spread that. So that would be one thing. The other thing is the report, Probable Futures and Radical Possibilities, which picks up this notion of agents of change and curators of knowledge. That at the moment, the website has gone down, but it will be on the website of an organisation called THET.
All right.
Because the APPG has closed down, but the reports will be that we did will all be on that. So look at an organisation called THET, which is a very interesting one anyway, because it's the one that sort of supports partnerships.
Fantastic.
But with African countries, for example. Yeah.
And well, thanks very much. You've been very generous with your time. And I think that's all there is to say. Thanks for being on the podcast, Lord Crisp.
Well, nice to see you, Dr. Zack, if you are using titles. And to hear, I'm pleased to know that there is optimism, because actually optimism can move stuff, but it needs to be realistic optimism, doesn't it? I don't need to tell you that.
Absolutely.
Yeah, great. Good to see you.
If you like the podcast, the best way to support it at this stage is to tell your friends about it and share it on social media. You can use the hashtag Healthy Discussions or my Twitter handle @MontereyZack to tell me your thoughts about this episode. In the description, you'll find more about our guests' work and their book recommendations. Thanks to Health Education England North East, Health Education England South West, and Medics Academy for supporting this episode. All of us at the Healthcare Leadership Academy are grateful for their support.